Hello everyone, welcome back to the series of lectures in rheumatology. Today we will be discussing about what is considered to be the king of rheumatology, which is rheumatoid arthritis. So let's start. So what exactly is this rheumatoid arthritis? Okay, so rheumatoid arthritis is again a multi-system autoinflammatory disorder which predominantly affects the joints. Okay, so this is a multi-system autoimmune disorder which predominantly affects the joints and it causes destruction of the joints. And what sort of joints are involved? It's predominantly the small joints. Okay, it's predominantly the small joints. But remember that rheumatoid arthritis can affect various other systems in the body as well. But the characteristic feature is that there is joint erosions and destruction of the joints. So, let us look at the epidemiology of rheumatoid arthritis. Rheumatoid arthritis is more common amongst the Native Americans. Amongst all the races, it's more common in Native Americans and it affects females more than males. It affects females more than males. And the age group that is commonly involved is the middle age, 40 to 60 years of age. Okay, so let us understand the etiology of rheumatoid arthritis. So there has been a lot of research which has been going on from the past several years to exactly understand the etiology, but we have been only able to find out few of them. So there is an interaction between genetic and environmental factors. So amongst the genetic factors, what we have to know is that MHC predisposition, especially the HLA-DR genes. So there is a characteristic gene which is found in up to 70% of the individuals with rheumatoid arthritis is this third hypervariable region of DR beta chain amino acids 70 to 74. So in this particular region of 70th to 74th amino acid, in the third hypervariable region of the DR beta chain, any mutation in that particular chain has been found to be an important predisposing factor for rheumatoid arthritis. Okay, so this is one which has been consistently shown to be positive and mutated in up to 70% of the patients who have been diagnosed to have seropositive rheumatoid arthritis. That is the reason why, if you don't remember anything, remember this one particular genetic predisposition. What is that? There is a mutation in this particular region between 70th to 74th amino acid, the third hypervariable region of DR beta chain. Other genetic factors which have been implicated includes mutations in PTPN22, STAT4 and PADD4. Very important, one word you have to remember is PADD4. Okay, so these are the genetic factors. Amongst the environmental factors which have been consistently positive is smoking. So, long-term smoking and even exposure to second-hand smoke has been found to be an environmental trigger for rheumatoid arthritis. Amongst the bacteria, the characteristic bacteria that you have to remember is Porphyromonas gingivalis. Okay, then viruses include EBV and parvovirus. So, whenever there is an interaction between this genetic and environmental factors and there is an environmental trigger in a genetically predisposed individual, along with production of antibodies which includes rheumatoid factor and anti-cyclic citrullinated polypeptide. So these two antibodies basically have a predisposition to go and affect the joints, and this is what results in RA. Okay, so this is about the genetic and the environmental risk factors associated with RA. In the recent times, we have come up with this concept which is called as preclinical RA. Okay, so what is preclinical RA? So preclinical rheumatoid arthritis basically refers to the situation where we have antibodies positive and genetic risk factors are also present, but there are no symptoms. Okay, there are no symptoms. Okay, so if you do MRI of the joints, you may find some evidence of activity or inflammation, but the clinical symptoms are absent, and this is what we call as preclinical rheumatoid arthritis, and the recent research is focusing on treatment of RA at the preclinical stage itself. Okay, this is just for our awareness. Fine. Now let us look at the pathogenesis of rheumatoid arthritis. So we have understood that there are certain genetic as well as environmental risk factors. Okay, environmental risk factors: smoking, Porphyromonas gingivalis is a bacteria and certain viruses. Genetic risk factors, you remember that third hypervariable region, and PADI4 predominantly, including PTP and 22. So once the genetic and environmental risk factors are activated in a patient who is having a predisposition to rheumatoid arthritis, so this results in autoimmunity. It results in autoimmunity. Okay. So the first step that is involved is the stimulation of what we call as the APCs. The APCs are antigen presenting cells. Okay. So these genetic and environmental factors are going to abnormally stimulate the antigen presenting cells. So these antigen presenting cells in the normal immune system are going to recognize foreign objects, and they are going to present these foreign antigens for our body or immune system to fight it back. But here you can have development of auto or self immunity. The antigen presenting cells are going to interact with the CD28 CD80 ligand. The CD80 is present on the antigen presenting cell and CD28 is present on the T cell, and they are going to interact and causes differentiation of the T cells into the T helper 1 lineage and T helper 17 lineage. Okay. So once the antigen presenting cells are stimulated, the T cells differentiate into T helper 1 and T helper 17 lineages. T helper 1 cells are involved in production of interferon gamma and TNF alpha. So if you have to remember what are the key cytokines involved in rheumatoid arthritis, remember interferon gamma and TNF alpha. Why is this important? Because nowadays we have directed therapies against these molecules. And stimulation of the T helper 17 cells involves production of interleukin 17, again TNF alpha, interleukin 6 and granulocyte monocyte colony stimulating factors. These factors are in turn going to stimulate more inflammation and migration of the macrophages into the joints. Okay, fine. So till here we are clear. Molecules that we have to remember: interferon gamma, TNF alpha, interleukin 17, interleukin 6 and GM-CSF. Okay. Fine. Now the next step is the T helper cells are going to interact with the CD40 ligand and CD40 interaction. Okay. So this is a co-stimulation that happens, and this is also another very important step because we can find targeted therapies to this as well. So this co-stimulation CD40 ligand interaction, CD40 is present in the B cell, CD40 ligand is present on the T helper cell, is going to stimulate the B cell to produce your antibodies which are characteristic in rheumatoid arthritis, which includes rheumatoid factor and anti-CCP antibodies. So this is very clear. Okay. The effector T cells using the interferon gamma interleukin 17 which was produced is also going to stimulate the macrophages. Macrophages are pro-inflammatory in nature, and these macrophages are going to migrate to that particular joint. Okay. So the macrophages are going to migrate to that particular joint. Alright. Now, also you can see that there is further stimulation of TNF alpha and interleukin 1, 6, 18, and what happens is that the fibroblasts are also stimulated. The smooth muscle cell fibroblasts are also stimulated. Now what happens after this is also very interesting. So the smooth muscle cell fibroblasts as well as the activated macrophages via the TNF alpha is going to act on one particular pathway which is called as the WNT-Dickoff pathway. Okay, WNT-DKK1 or WNT-Dickoff pathway, which is the predominant pathway which is maintaining the balance between your osteoblasts and osteoclasts in the bones. Okay, so what happens is that there is stimulation of the WNT pathway, and when the WNT pathway is active, the pre-osteoblasts are converted into osteoblasts. Now what happens is TNF alpha is going to cause stimulation of Dickoff1, which inhibits this formation of pre-osteoblast to osteoblast, and as a result of which the osteoblast formation is stopped. Okay. At the same time, they act via the rank L, which is your rank and rank ligand, which causes stimulation of the pre-osteoclast and it increases the osteoclast formation. Okay, so there is an imbalance between your osteoblast and osteoclast formation, as a result of which this finally results in your erosions which is seen on the bones. Okay, fine. So this is on the whole about how this inflammatory process in rheumatoid arthritis is happening. Clear? So let us just revise this. So first is there is a trigger of autoimmunity and antigen presenting cells are stimulated, which stimulate the T cells to differentiate T helper 1, T helper 17 cells. The key cytokines you have to remember are TNF alpha, interferon gamma and interleukin 17, and these T helper cells on one hand through CD40 ligand interaction, they cause stimulation of B cells, production of autoantibodies. At the same time, they also cause stimulation of macrophages, fibroblasts, which causes inflammation within the joint, and they also alter the WNT-Dickoff pathway, causing imbalance between your osteoblast and osteoclast, finally resulting in bone damage. Okay, fine. So this is about the pathogenesis of rheumatoid arthritis. Now, with all this inflammation, what is the pathological hallmark that you see? And this is what we call as a pannus formation, right? So let us look at this a little bit more in detail. Okay, so a normal bone is usually surrounded by what? It is surrounded by a synovial capsule, right? And within the bone you have some amount of a cartilage and a synovial fluid which is present between the two bones. Now what happens in RA is that with this excessive amount of inflammation and infiltration of the macrophages into the joint cavity, the osteoclasts are going to cause destruction of the bone. This is where the osteoclasts are going to cause destruction of the bone. At the same time, there is a synovial hypertrophy. So the synovial membrane is going to get hypertrophied with a lot of inflammatory cells. And this particular synovial hypertrophy with inflammatory cells is what we call as the pannus. So ultimately, this entire inflammatory process results in pannus formation, it results in bone erosion and cartilage destruction. Alright, and this is what is responsible for the various symptoms of rheumatoid arthritis. Okay, so this is clear. So let us look at the patterns with which rheumatoid arthritis can present. Okay, so first is your palindromic pattern. So what is the meaning of palindromic pattern or palindromic rheumatism? So here you have arthritis which is very similar to the symptoms of rheumatoid arthritis. Less than 5 joints are involved during a flare. This flare usually lasts for less than a week, right? So few joints are involved, it lasts for less than a week and then it settles down. The patient remains completely asymptomatic between 2 flares, but the flares are recurrent in nature. The flares are recurrent in nature. So you have multiple joint pains, arthritis, then the patient is asymptomatic in between and then the flare recurs, and this is recurrent in nature and they are usually asymptomatic between the flares and there is no evidence of erosions if you do an X-ray. This is what we call as palindromic rheumatism. And why is it important? Because palindromic rheumatism has around a 10% chance per year of getting converted into a full-blown rheumatoid arthritis, right? So palindromic rheumatism is in itself a preemptive form of rheumatoid arthritis. The second form or pattern of onset of RA is arthritis robustus. So arthritis robustus is usually seen more commonly in males, right? And it shows the presence of severe deformities. Arthritis robustus shows the presence of severe deformities, but the absolutely surprising part is that they are asymptomatic at that particular time. They may have severe deformities, but they are asymptomatic. This is arthritis robustus. The third pattern of onset of rheumatoid arthritis is your rheumatoid nodulosis, where you see the presence of multiple subcutaneous nodules. Okay, so this is about the different patterns of onset of rheumatoid arthritis. Now let us look at the most common joints which are involved in RA. So 90 to 95% of the time, this is the similar photograph and it is used to compare your osteoarthritis from rheumatoid arthritis. So 90 to 95% of the time, it is usually the metacarpophalangeal joints which are involved, right? Followed by which you can see 75 to 90% and 75 to 80% of the time, it is the interphalangeal joint. It is the first proximal interphalangeal joint and the wrist joint which are the most commonly involved joints. And you can see that this is a bilateral symmetric small joint arthritis, right? So we would not be wrong if we say this is a bilateral symmetric small joint arthritis, and this mainly involves the metacarpophalangeal joint, first proximal interphalangeal joint and wrist joint, right? So though it is predominantly small joint involvement, you can see that 60 to 80% and 50 to 60% of the times you can find ankle and knee joint involvement, as sometimes pelvic involvement and temporomandibular joint involvement can be present, but this is comparatively rare. So always remember the joints which are not involved is distal interphalangeal joint is not involved. The first tarso-metatarsophalangeal joint is usually not involved. Okay, so this is about the pattern of joints, most common joints involved in rheumatoid arthritis. So let us look at the clinical features of rheumatoid arthritis one by one. So first we'll be looking at predominantly the articular manifestations. What is the pattern of arthritis? This arthritis is definitely an inflammatory arthritis. It's an inflammatory arthritis. So if it is an inflammatory arthritis, how are they going to present? They are going to present with early morning stiffness. Early morning stiffness which lasts for more than 30 minutes, and it increases with rest, and associated swelling of the joint can be present. Okay, so that is your inflammatory arthritis, right? Let us look at the deformities in rheumatoid arthritis one by one. The first is a boutonniere or a buttonhole deformity. So the first deformity which is very common is a boutonniere or a buttonhole deformity, where the proximal interphalangeal joint is flexed whereas the distal interphalangeal joint is extended, right? So the proximal interphalangeal joint is flexed whereas the distal interphalangeal joint is extended. This is what we call as the buttonhole deformity. So if you see here, this is a buttonhole deformity. Okay, fine. Next, what is a swan-neck deformity? This is just opposite to the boutonniere deformity, where the proximal interphalangeal joint is extended whereas the distal interphalangeal joint is flexed, and it looks like a swan neck. Okay, and why does this happen, the swan neck deformity? This is because the flexor digitorum superficialis can be ruptured as a result of rheumatoid arthritis and results in a swan neck deformity. So can you see here that there is a swan neck deformity here? Okay, so this is the first two deformities. Then what is a zigzag deformity? So in a zigzag deformity, there is a radial deviation of the wrist and ulnar deviation of the metacarpophalangeal joints. Radial deviation of the wrist with the ulnar deviation of the metacarpophalangeal joints is what we call as a zigzag deformity. Then piano key styloid. So the radial styloid, often there can be rupture of the collateral ligaments in the which holds the styloid process, and the styloid process will appear to be floating, and this is what we call as the piano key styloid. Okay, then there can be complete destruction of both the hands, and this is what results in a deformity that we call as the opera glass appearance, where there can be complete destruction of both the hands. Then what is the hitchhiker's thumb? So a hyperextended thumb is what we call as the hitchhiker's thumb. So there is lack of flexion and hyperextension of the thumb, which is called as the hitchhiker's thumb, right? So apart from this, these are predominantly the deformities which can be seen in the upper limb. In the lower limb, you can find hallux valgus, pes cavus and forefoot varus. So this triad, which is hallux valgus, pes cavus and forefoot varus, right? So this is about the various deformities which can be found in rheumatoid arthritis. So with this, we've come to the end of the part 1 on rheumatoid arthritis discussion. In the next part, we'll be discussing further about the clinical features and about the management of rheumatoid arthritis. Thank you.